Good morning, everybody. Let's continue our discussion on abnormal psychology with the discussion of disorders most associated with childhood and with childhood. Okay, so let's pull up the screen and sorry, childhood and adolescence. Um, So we will cover a lot of the major diagnoses you would commonly encounter if you pursue a career in mental health treatment, and such as autism and childhood conduct disorder, as well as oppositional defiant disorder. I'm gonna kind of bypass the disorders concerning intellectual disability and learning disorders. Now these are disorders which you certainly will encounter. Yeah, if you pursue a career in mental health, particularly working with children and adolescents. Um, but I'm going to bypass it for purposes of our video lecture because I think some of that discussion you can pretty much garner from the textbook and from the PowerPoints. Okay, well, first of all, what we really need to make clear at the get-go is that mental disorders among children are fairly common. One in 10 children suffers from a mental disorder, severe enough to impair, social, educational functioning. Yeah. That said, interesting enough, anywhere between 60 to 80% of children with mental disorders fail to get appropriate treatment. Okay, we'll talk about some of the factors that may contribute to this. Alrighty. The interesting thing with childhood and adolescent disorders too is that some disorders are very quick to get the attention of adults, more so than other disorders. Okay, such as ADHD. That catches the attention of parents and teachers very quickly. In part because it really annoys parents and teachers when someone is ADHD. Alrighty. But when a child is depressed or anxious, maybe social phobic, and so on, yeah, that doesn't get the attention of adults quite so quickly. Yeah. Quiet children, for whatever combination of reasons, don't capture the attention of a parent in terms of concern regarding of mental health issues. Yeah. Um, Perhaps a lot of the time, a lot of those children are just perceived as being good children, yeah, good, quiet children. And, I'm not casting aspersions against parents or teachers. Parenting and teaching, they are tough, tough jobs. So a quiet, child who's kind of reserved, will maybe perceived by many parents and adults as, being a good child, a good, quiet child. Although, many of those children, I'm sure some of them are just kind of introverts or quiet or mellow children. There are many of those children, but perhaps many of them do suffer from, serious depression or anxiety, um, but it's harder for adults to notice it. Yeah. Also, when adults suffer, yeah, from depression or anxiety, they're in pain, psychological, emotional pain. Yeah, they tell people. Alrighty. They usually tell their friends or family or significant others that they're unhappy or bummed out. Children less so. Yeah, they're less inclined to do that for a number of reasons. Part of which is maybe even identifying feelings and what they're about. Yeah, but certainly for some children, there may be this dynamic of not complaining to parents or reporting negative feelings like that. Yeah, except for when it's something like um, uh, negative interaction with a sibling or a friend. But when they're having a sustained kind of a mood disorder like a depression, it may not occur to some children that that's something to communicate to adults. What are some unique aspects of childhood disorders? Some of which we kind of just touched on. Um, First of all, development proceeds at different rates for different children. And when we're talking development, we're talking broadly, right? So social development, intellectual development, emotional development. Yeah. So different children, the rate of being able to identify feelings, talk about feelings, and so on. Yeah, problem solve, communicate with others about feelings will differ with children. you know, um, as a function of a number of things. Just as is the case with, let's just say, verbal behavior. Yeah, some children start really articulating a lot of words at about age one. Some more so at age two. Yeah, and we know of the occasional child who, although they may be capable of speaking, don't speak at any great length until about age 3 or 4. Yeah? So there is a large degree of variation. Yeah, with very often situations where children in the latter age group, like 3 to 4, doing absolutely fine in school later. Yeah, and children, just because they might speak a lot, at age one, that doesn't necessarily determine or predict that they're going to be such great successes necessarily later on in education. So children can develop at different times and at different rates, yeah, which can sometimes make the identification of problems kind of tricky for parents and those who have a lot of contact with the child. Okay. Childhood problems sometimes are a little less predictable. Um, when a child is in a negative mood, it may be hard to predict to what extent. That's just going to vary, right? And that it isn't prognostic. It doesn't suggest a negative prognosis in terms of mood in the next few months. Whereas adult, moods tend to be a little more stable and more predictable in that regard. Okay. As mentioned before, children can't communicate like adults in terms of, cognitively identifying emotions, yeah, different children at different times. And again, because of uh, s- situational circumstances. Yeah. For example, in the school setting, yeah, children may not be socialized in many respects to, identify feelings such as, being really seriously sad, yeah, or being, socially phobic. Yeah. Children may feel pressures to not say things like that, right? Not rock the boat, not to bother the teacher or parent for that matter. Yeah. And also, let's talk about social phobia. Yeah. Maybe perhaps the idea, if a child has a feeling that they're really scared of other kids, maybe they feel and think that that's not something they're supposed to identify and report. Yeah, that they should I mean, adults feel pressure to be quote unquote normal, right? To say the right answers, to not say that they're social phobic. Okay, well, the pressures are just as much, if not more so, for many of these things, like social phobia. The idea for a child to actually state to an adult that they're scared of other children, and even like the idea with social phobia, right? A real important component is being evaluated negatively by others. Children don't think that way, right? They might think, Johnny or Mary doesn't like me, but they're not going to think in terms of, they're going to judge me poorly. Later, maybe in later childhood, children are able to describe their internal states that way, but certainly not early childhood. Yeah, more children are going to have greater difficulty using words like judge and evaluate and so on. Um, and adults can also differ in their assessment of children. Yeah. We got to keep in mind when the parents, when the teachers, when certain teachers, when after school program adults see a child, yeah, they see the child in different contexts. Alrighty. And given the context, it may be easier, more challenging to identify emotional behavioral problems in children. Okay. And also different adults, right? Be it the parents at home, be it different teachers across different classes, be it adults in after school programs, right? They will all have different things that they're looking out for, that they're concerned about. Yeah. And will assess children differently, have different cutoffs in terms of what's a concern and what's not a concern. All righty. Um, Okay. And sometimes childhood problems are often specific to a context. Yeah. So if a child is social phobic, right, this is something that a parent very well will not see, because maybe it's an only child, or they have siblings, but they're fine with siblings. But the parent may never get an opportunity to see their child with children who are strangers to the child, right, and who would be the stimulus for social phobia. Alrighty. So let's look at our first category of disorders, autism and autism spectrum disorders. Alrighty. Now, before proceeding, let us turn to our TSM storybook and look at the case of rocking and reading. Alrighty. So, rocking and reading. So, in this case, we have a 22-year-old Betsy was referred for evaluation by the staff of her group home. She had been placed in the group home some 3 months previously, following court-ordered deinstitutionalization from a large residential facility for the retarded. Okay, dated term, just reading from the book here, but now the official term is intellectual disability, not mental retardation. The evaluation was requested because Betsy, quote, didn't fit in with other patients and had developed some problem behaviors, particularly aggression directed toward herself and, less commonly, toward others. Unlike other patients in the group home, she tended to, quote, stay to herself, close quote, and had essentially no peer relations, although she did respond positively to some staff members. Her self abusive and aggressive behavior usually were triggered by changes made in her routine. Self abusive behavior consisted of repeated pounding of her legs and biting of her hand. Betsy had been placed in residential treatment when she was age 4 and had remained in some kind of residential setting ever since. Her parents had both died, and she had no contact with her only sibling. At the time of her transfer to the group home, she was reported to have had several abnormal electroencephalograms, but no seizures or other medical problems had been noted. When last given psychological tests, she achieved a full scale IQ of 55 with comparable deficits in behaviors. Inadaptive behaviors. During the evaluation, Betsy spends much of her time reading a children's book she discovered in the waiting room. Her voice is flat and monotonic. She is unable to respond to any questions about the book she's reading and reacts to interruptions of her ongoing activity by pounding both legs with her fist. She rocks back and forth continually during the interview. She makes eye contact with the examiner initially, but otherwise seems oblivious to everyone around her. She neither initiates activities, imitates the play of the examiner, nor responds to attempts to interest her in alternative activities such as playing with a doll. From time to time, she repeats a single phrase in a monotonic voice, quote, blum, blum, close quote. Physical examination reveals extensive bruises covering most of her lower extremities. Betsy was the product of a normal pregnancy, labor, and delivery. She was noted to have been an unusually easy baby. Her parents had first become concerned when she failed to speak by age 2. Motor milestones were delayed. Her parents initially thought that she might be deaf, but this was obviously not the case as she responded with panic to the sound of a vacuum cleaner. As a young child, Betsy had been observed to, quote, live in her own world, close quote, had not formed attachments to her parents, had idiosyncratic responses to some sounds, and always became extremely upset when there were changes in her environment. By age 4, Betsy was still not speaking, and placement in the state institution was recommended following a diagnosis of childhood schizophrenia. In the year after her placement, Betsy began speaking. However, did not typically use speech for communication. Instead, she merely repeated phrases over and over. She had unusual ability to memorize and became fascinated with reading, even though she appeared not to comprehend anything she read. She exhibited a variety of stereotyped behaviors, including both body rocking and head banging, requiring a great deal of attention from the staff. Okay, so that was the case of rocking and reading. Okay, very good case illustrating a lot of the classic symptoms associated with autism spectrum disorder. Alrighty, now the diagnosis originally, yeah, prior to the DSM-5, we had separate diagnoses for autism, including just plain autism, childhood disintegrative disorder, as well as Asperger's disorder. Yeah, the latter, Asperger's, being characterized, being just characteristically capturing a higher functioning individual. Yeah, individual who may be able to take high school, maybe even college classes. Yeah, but still has the significant impairments quite that are characteristic of autism disorders. But these disorders have been kind of collapsed into autism spectrum disorder with the idea that it's understood that people vary on this continuum, Yeah, but they're still given the diagnosis, but the level of functioning is described as either mild, moderate, or severe. Yeah, as opposed to using the separate diagnoses autism, childhood disintegrative disorder, and Asperger's disorder. Okay. Generally, autism, as captured in the case here, as you may be familiar with cases that you've maybe encountered, include significant disturbances in the acquisition of cognitive, language, motor, or social skills. Okay, it's generally a chronic condition. Sometimes some combination of medication and psychological, um, treatment, um, primarily through behavioral interventions, can really increase an individual's function in terms of communication skills, eye contact, um, using words, using language, as well as social functioning. Yeah, can lead to significant improvements, but the condition tends to be fairly chronic, and there'll always be a presence of problems in these arenas, in these areas. It includes the ability to respond to others. The ability to respond to others don't normally develop in the first 3 years of life. Yeah, as you may recall, with the case of Rocking and Reading, right? That she didn't start speaking until about age 2. Okay. Now, as I mentioned before, right, just because a child hardly speaks at age 2 does not mean that that's a rule in for autism. All righty, which can go to how because of developmental rates along different areas, right, can vary for children. It may be hard to discern exactly what's going on with the child when they don't speak or they hardly speak by age 2. In this case, it was clearly related to the communication difficulties associated with autism. Yeah, it's also characterized by lack of interest in people. Yeah, even with family members. Yeah, and certainly not the same level of engagement with family members as with a child not suffering from autism. Alrighty, it's typically characterized by disengagement, lack of eye contact, lack of attempt to communicate, to physically reach out, and so on. Yeah. Um, Individuals also fail to develop language or develop abnormal language development, as kind of illustrated here with Rocking and Reading. And I'm sorry, I just wanted to find. Oh yeah, the case here was that of Betsy. Yeah, and the case starts off with her being 22, but the case kind of nicely illustrates how these problems with Betsy started, or was first observed on or about the age of 2, and then kind of lays out her childhood and early and adolescent history. Yeah. Also, very those suffering from autism will demonstrate a low tolerance to environmental change, as well as a very high sensitivity at times to external stimuli like lights and sounds. Yeah, it is not uncommon that those suffering from autism sometimes experience those sensations of light and sound, which may not disturb a non-autistic individual, but because of the high sensitivity in the autistic individual, this can be particularly distressing to the child, whereby they have to find ways to decrease the level of stimulation they're experiencing. Yeah, sometimes it might be bought, and very often that's part of what the isolating oneself from others may be a part of, may be related to. Yeah. Um, And we also see abnormalities in motor behavior. It may be repetitive motor behavior, like spinning certain objects, and so on. Okay. As mentioned, duration is typically from early childhood. To be diagnosed, it needs to be distressing or impairing the child's social occupational functioning, which regrettably, in most cases, that's what's going to be happening. Yeah. Um, and it should be differentiated from these other situations. You want to be sure that you're not dealing with a non-autistic child who just may have a particular preference for order and repetition. Many children at certain points in early middle childhood who are non-autistic may have kind of OCD kinds of behaviors. Yeah, with like how food is placed, on on their dinner plate, right? You may recall instances of children of your own or nephews and nieces, right, who need to have the keys and parents not parrots, peas and carrots not touching the mashed potatoes, right? Otherwise, they have a fit. Okay, children do that, alrighty, but many children they get out of it. It's a phase. It might last, few several months or a year or two. Yeah, but most children get out of it. Alrighty. You want to be sure it's not some other just stereotypic movement disorder. You can see autism is not just about movement. Yeah, it has far more to do with cognitive impairment, interpersonal impairment, sensory impairment. So, it affects a whole lot of areas of functioning. It's not schizophrenia, right? Schizophrenia is very distinct, as I hope we're distinguishing from here. But it's almost analogous in terms of how many parameters or areas of functioning are impaired for the autistic individual. Okay, here are a couple of video clips we might watch and discuss. I think we at this point would have done the teen and police video. We may look at the Carly video and kind of discuss Carly's experience with autism. Yeah, Carly being a case of Asperger's. Um, Now, what causes autism? Yeah. Well, we have some ideas based on the research. It seems to have a clear biological genetic component. Yeah. There are brain abnormalities which may have occurred sometime during the prenatal period. Maybe prenatal risk factors include things such as exposure to influenza infection, any kind of maternal prolonged fevers, and these prenatal abnormalities in the prenatal environment seem to may have produced some abnormal wiring in the brain circuitry while the brain was developing during this very vulnerable period for the brain. Alrighty. In terms of the treatment, um, it involves both biological as well as psychological. The biological interventions tend to be medications, and they're usually involved at decreasing tantrums, aggressive behavior to oneself or others, and any other kinds of problematic stereotyped behavior which might be affecting their ability to relate with others, like if there are gross arm motor movements, yeah, and so on, that are keeping them from being able to adapt socially. Okay, antipsychotic, anticonvulsant medications, or the combination of the two may be used. Psychological interventions tend to be more behavioral focused, yeah, in terms of using behavioral modification techniques to increase, tolerance to sensory stimulation, helping the child develop ways of managing the distress that's caused by um, high levels of visual or tactile or auditory stimulation. Yeah, problem solving with the family and educators in terms of how the child can be placed in a different physical environment so that they can manage, right? Maybe one with a lowered um, luminosity in terms of the lighting in the room, or decreasing the amount of extraneous noise. Yeah, and also understanding how the child may be, if the child is particularly sensitive to tactile stimulation and just doesn't tolerate being hugged or held, or having their hand held, just as non-autistic children can not only can do but desire. Yeah, helping the family understand how to relate with the child, how to make any kind of physical contact with the child. But again, a lot of it is behavior modification in terms of also increasing the child's ability to use words, to communicate by way of language, keeping eye contact, um, you know, um, developing the social skills with relating with peers and family members and teachers. And the behavior modification can be incredibly effective in increasing a child suffering from autism and their ability to function along all these parameters. Yeah, and sometimes the smallest changes can make huge difference in terms of how the child's ability to be effective in their environment. Yeah, the ability, even if they don't make eye contact and so on, if they can use language, yeah, with others to express, their wants and feelings and so on. That's huge. That can be huge for a child. Yeah. So the behavior modification interventions, um, can have a significant play in functioning. But as mentioned before, as a general matter, the problems in autism are chronic, um, but it is also on a continuum with those who need a lot of assistance and guidance and help with managing themselves personally, personal hygiene, and so on, and with eating and going through the day, going through their daily routines. Yeah, whereas others can be very high functioning, can take high school courses, maybe even college courses, may be able to have a part-time or full-time job. Um, yeah, and may even be able to live somewhat independently with supervision. Okay, so the range of abilities on the continuum is fairly wide. Okay, I'm gonna bypass intellectual disability. This was what was formerly referred to as mental retardation, but the title was changed to take out the stigma attached to the word mental retardation. Yeah. Otherwise, the criteria are fairly the same, and we'll just kind of bypass this because again, I think the text in the PowerPoint kind of lay out the important issues with intellectual disability fairly well. Um, and same with the learning and communication disorders. Okay, and let's get into the disruptive behavior disorders. But with that, I'm going to take just a quick break here. Okay, everybody. And with that, let us continue. Alrighty, so let us talk about the category of disruptive behavior disorders. Alrighty, and we'll start off with the one that I think most of us are kind of familiar with, either with ourselves or family members, or we probably each of us know somebody who has been diagnosed with attention deficit hyperactivity disorder. And I have to say, given how rambunctious, that's a nice word for pain in the ass I was in grade school and middle school. I if I had a different set of parents, I probably would have been sent to a psychiatrist and diagnosed with ADHD. Yeah, many kids, particularly boys, are just a few criteria off being diagnosable as suffering from ADHD, and that's actually what makes the disorder kind of a point of dispute, at a point of dispute and debatable, because it's argued by some that the criteria are so broad that it can apply to many, not all children, but many children. Yeah. And it raises the question if many of these children are actually suffering from a mental disorder, or they're just on the range of normal behaviors that children demonstrate in structured settings like school and so on. Um, and so, but that said, I easily could have been diagnosed as suffering from ADHD. With that, let me share with you a case, besides my case, of ADHD with the case of Into Everything, another DSM bedtime story. So, with that, Eddie, age 9, was referred to a child psychiatrist at the request of his school because of the difficulties he creates in class. He has been suspended for a day twice this school year. His teacher complains twice for a day twice this school year. Twice. I got him beat on that one. His teacher complains that he is so restless that his classmates are unable to concentrate. He's hardly ever in his seat. He roams around the class talking to other children while they are working. When the teacher is able to get him to stay in his seat, he fidgets with his hands and feet and drops things on the floor. He never seems to know what he is going to do next and may suddenly do something quite outrageous. His most recent suspension was for swinging from the fluorescent light fixture over the blackboard. Because he was unable to climb down again, the class was in an uproar. I can identify with Eddie. His mother says that Eddie's business has been difficult since he was a toddler, and that as a 3-year-old, he was unbearably restless and demanding. He has always required little sleep and been awake before anyone else. When he was small, he, quote, got into everything, close quote, particularly in the early morning when he would awaken at 4:30 a.m. or 5 a.m. and go downstairs by himself. His parents would awaken to find the living room or kitchen, quote, demolished. When he was age 4, he managed to unlock the door of the apartment and wander off into a busy main street, but fortunately was rescued from oncoming traffic by a passerby. He was rejected by a preschool program because of his difficult behavior. Eventually, after a very difficult year in kindergarten, he was placed in a special behavioral program for first and second graders. He is now in a regular class for most subjects, but spends a lot of time in a resource room with a special teacher. Um, when his own when with his own class, he is unable to participate in games because he cannot wait for his turn. Psychological testing has shown Eddie to be of average ability, and his achievements are only slightly below expected level. His attention span is described by the psychologist as, quote, virtually non existent. He has no interest in TV and dislikes games or toys that require any concentration or patience. He is not popular with other children and at home prefers to be outdoors, playing with his dog and riding his bike. If he does play with toys, his games are messy and destructive, and his mother cannot get him to keep his things in any order. Eddie has been treated with a stimulant, methylphenidate, in small doses. While taking the drug, he was much easier to manage at school in that he was less restless and possibly more attentive. So that's the case of Into Everything, Eddie. Alrighty, great case. Definitely captures this diagnosis. Alrighty. Well, as you've gathered, the symptoms that characterize ADHD include inappropriate attentional problems, impulsivity, and motor hyperactivity. Okay, males tend to be diagnosed about 3 to 4 times more frequently than females. Yeah, but that is not to say that females may be suffering from ADHD. What and the reason why they may be underdiagnosed, and we know they've been underdiagnosed for a long period of time, and now the field of psychology and psychiatry is quite aware that females, little girls, can suffer ADHD just like little boys. But the reason why they've been kind of under the radar is that for girls, ADHD may manifest itself more in terms of the problematic attentional problems and not so much the motor hyperactivity. Yeah. And it's that motor hyperactivity, which is far more in boys, that gets the attention of teachers or parents. Yeah. Which then gets the child referred for diagnosis and treatment. Okay, it kind of gets to that old notion of sometimes what a mental disorder is it something that disturbs the individual, distresses them, or distresses others? And if it's the latter, for a child, they're more likely to maybe be evaluated and diagnosed and receive treatment. As opposed to, as in the example with girls who demonstrate lower motor hyperactivity, they're less likely to be kind of labeled as a problem, right? Because they very well are not distressing or annoying an adult. Yeah? But you start becoming annoying enough to an adult, they may want to consider ADHD. So, what are some of the causative factors for ADHD? Well, there certainly seems to be a genetic component, tends to run in families. It may be a function of prenatal complications. Um, poor, it certainly may be a function of poor parenting skills. Yeah, in terms of setting limits, setting structure, utilizing behavior modification techniques like reinforcement appropriately and consistently. Lead poisoning has been implicated in causing ADHD. Yeah. And also in the brains of children with ADHD, there seems to be some disruption in terms of electrical um, activity in the prefrontal cortex. We need to see the presence of symptoms for at least 6 months before the age of 12. All righty. Um, and it has to cause either the child distress or impair social occupational functioning. And as I think you got a sense of with the case of Eddie, yeah, it's not something that just frustrates. If a child is really fits the diagnosis of ADHD, Yeah, odds are they're not just having problems with adults and teachers, but they're having problems with peers too. Yeah, because anyone who has such poor attention and is that impulsive, getting out of their chair, not listening to people, and so on. Yeah, and demonstrate that kind of motoric hyperactivity where they're climbing up the wall. Um, you know, it's going to impair their ability to make friends. Yeah, and very often children who are uh, appropriately diagnosed as ADHD, they almost always have problems making friends. Yeah, and sadly, and they end up being kind of alone at times in the school setting. Okay, um, now this is one of those. Now, treatment includes Ritalin, Adderall, okay, which can be highly effective in terms of increasing attention and leading to a decrease in, the excessive impulsive motor behavior. Alrighty. The thing that's certainly a question, though, about the diagnosis, but also about the treatment, is the fact that Adderall is also effective with those who are not diagnosed with autism. It just generally increases attention and also facilitates, so increases attention for anybody. As you may or may not be familiar, if you see the molecular structure of Adderall, yeah, it's incredibly similar to cocaine. It just varies by one or two molecular branches, but it looks almost identical. Yeah. So it kind of leads to this question of whether, to what extent this is a treatment for ADHD, or is this just a cognitive enhancer for people in general? Yeah. And to be quite frank, it is a cognitive enhancer for people in general. Yeah. It's not like so much like an antidepressant. Yeah. Which particularly is effective for those with mood disorders. Yeah. Not so much so with those without mood disorders. Alrighty. It's not a big happy pill. It's not going to be something that's going to be making you into a grinning idiot if you use an antidepressant and you're not depressed. Okay, but Adderall that will spike up your attention. Okay, increase your attention. Okay, um, so these stimulants tend to increase the presence of norepinephrine in the prefrontal cortex. That's one of the ways in which they function. Yeah. Treatment also, though, should include behavior therapy. Yeah. And it's also very possible for a child to be on Ritalin or Adderall for several months or a year or two and then not use it. Yeah. And that's one of the things that's also kind of good news. That's a bit of good news with Adderall is that a lot of patients, after a period of time, if they feel that they don't need to get it, need to continue it, they can taper themselves off. They can taper not themselves, but with the guidance of a physician, they can be tapered off Adderall successfully. Okay. Behavior therapy usually involves with children parent training. Yeah, so it's actually a lot of family work in terms of helping parents with parent training. Yeah, to apply behavior modification techniques in a way that they can, increase attentive, um, you know, um, behavior and then decrease, right, the motoric behavior, the um, impulsive behavior, help the child develop a certain frustration tolerance, right? As opposed to just getting out of their chair and attending to their impulses. Alrighty then, what is conduct disorder? Okay, well, as the term connotes, yeah, it's a childhood disorder characterized by aggressive behaviors, a breaking of rules, yeah, and not following, the structure of either the school setting or the home setting. Yeah, this is the kind of child who is the quote unquote problem child. Yeah, the kind of child who gets into a lot of fights with other children, has a hard time empathizing, demonstrating caring behavior, so has a lot of social impairment, and also is likely to demonstrate that same degree of disagree of inability to follow rules with parents, with teachers, and so on. Okay, now those with conduct disorder, yeah, can be treated and can be treated quite effectively. There are effective behavior therapy approaches that can be used with children suffering from conduct disorder. In other words, modifying the rule breaking, aggressive, hostile behaviors into pro social behaviors. It takes work and it takes a lot of commitment by all the adults in the individual's life, teachers, parents, and so on, in terms of um, utilizing behavior modification techniques um, in a consistent manner to increase pro-social behaviors and diminish the aggressivity and antisocial behaviors. Yeah, so there are effective treatments for conduct disorder. All right, let's look at a case of conduct disorder because I don't think my description quite captures it quite as well as the case of I'm not right up here. Philip, age 12, was suspended from a small town Iowa school and referred for psychiatric treatment by his principal. The following note came with him. Okay, this is a note from school. This child has been a continual problem since coming to our school. He does not get along on the playground because he's mean to other children. He disobeys school rules, teases the uh, patrol children. I think that's the people like the junior police officers with the stop signs and yellow hats. Um, Steals from the other children and defies all authority. Philip keeps getting into fights with other children on the bus. He has been suspended from cafeteria privileges several times for fighting, pushing, and shoving. After he misbehaved one day at the cafeteria, the teacher told him to come up to my office to see me. I presume this is the principal. He flatly refused. He flatly refused, lay on the floor, and threw a temper tantrum, kicking and screaming. The truth is not in Philip. Wow, that's kind of a powerful statement. Um, well, to say that he lies. When caught in actual misdeeds, he denies everything and takes upon himself an air of injured innocence. He believes we are picking on him. His attitude is sullen when he is refused anything. He pouts, and when asked why he does these things, he points to his head and says, quote, because I'm not right up here, close quote. Kind of concerning. This boy needs help badly. He does not seem to have friends. His aggressive behavior prevents the children from liking him. Our school psychologist tested Philip, and the results indicated average intelligence, but his school achievement is only at the third and low fourth grade level. Okay, and if he's 12, you should be at the sixth grade level. The psychiatrist learned from Philip's grandmother that he was born when his mother was a senior in high school. Her parents insisted that she keep the baby and help rear him. Most of his upbringing has been by his grandparents, however. Philip was, quote, 3 months premature, close quote, and a, quote, blue baby, close quote, requiring oxygen for 24 hours. Shortly after his birth, Philip's mother ran off with a man, married him, and had a second child. The marriage broke up and she left the child with its father. It. Philip has had no contact with his mother since she left him. Philip's toilet training was not successful and he remained a bedwetter for some years. At age 5, his maternal grandparents adopted him because they were afraid that his mother might someday claim him. He showed anxiety at separation from his grandmother when he began school. He was then in a serious car accident in which his grandmother was injured and one person in the other car killed. Philip did not appear to be injured, but seemed to have some transient memory loss, probably a direct, immediate result of the impact. Subsequently, he had nightmares, fear of the dark, and exacerbation of his fear of separation from his grandmother. Philip's school program was not good. He repeated third grade. His school progress, sorry, was not good. Not that the program was not good. He repeated third grade and then was in a special class for underachievers. His grandmother recalls that Philip's teacher complained that, quote, he, quote, could never stay in his seat, close quote. A few months before the consultation, Philip was seen in a mental health clinic and placed on some mild tranquilizers. A 3-month return appointment was arranged, but the school suspended him before that date. Alrighty. Um, so a lot of stuff going on with I'm not right up here. Yeah. The case of Philip. Alrighty. Um, Well, we can see that there are a lot of possible contributing factors. Yeah, a family background, current um, maybe home setting, just the stability or lack of the current home setting, gee, even medically, right? Possible head injury. We can see a lot of social problems that Philip was experiencing. Okay. Oh, I wanted to get to the thing about lying. Yeah, certainly can be a very classic behavioral problem among conduct disordered children. Now, one of the things to also keep in mind is, and I want to make clear first before I say the thing to keep in mind. The first thing is that many children with conduct disorder, yeah, can be treated effectively. Alrighty. That said, um, antisocial personality disorder has been correlated significantly with childhood conduct disorder. Alrighty, so if conduct disorder is left untreated, yeah, you could be setting the child up to grow and to be diagnosed at a later point as suffering from antisocial personality disorder. Okay, now you can just want to make it abundantly clear, you can have CD and never suffer from antisocial personality disorder. But that's not to say that there's no relation between the two, as just pointed out. Okay. Symptoms have to occur within, duration of the symptoms have to occur within a 1 year period, all these problems, with about a one plus month of these symptoms in the past 6 months. Okay. One or more of the symptoms in the past 6 months. Okay. So we got, you can see kind of a wide window. Yeah, duration of symptoms occurring within a year, right? That's one of the wider time frames, right? Usually it's like 6 months on average, most of the time frames. This one we're given a wider time frame. Again, probably taking into account how many children may have phases of being aggressive or rule breaking or lying, and so on. Yeah, but that it with parental structure and so on. Yeah, that many children who go through these kinds of phases get through those phases. Alrighty, but if they last for about a year period with about one plus symptoms within the past 6 months, again, and with the other characteristics just described, the child may be diagnosed with suffering from conduct disorder. Okay. Moving right along, oppositional defiant disorder. Okay, it's also characterized by negativism, hostility, being temperamental, but particularly with authority. Okay, so this is I just want to touch on this disorder quickly to distinguish it from conduct disorder. At first glance, at least to authority figures like parents and teachers, the child may look conduct disorder. Okay, but here's the big distinguisher. If you see this, the child being absolutely fine with other children, not aggressing towards other children, not lying towards other children, yeah, that they seem to have some friends, or many friends, but the negativity, hostility, and so on is directed to authority figures, then you have a different issue. You have oppositional defiant disorder. Okay, the window is much less. All you need is the duration of symptoms for about 6 months, more or less daily for age 5, and weekly for older children, and so on. Okay, so that's an important one to kind of, they can often be misdiagnosed. So this is something you want to be clear on that distinction and collect your behavioral data. Yeah, just because you have 5 teachers and both parents describing the child as aggressive, lying, breaking rules, throwing temper tantrums, before we presume conduct disorder, find out about their social functioning, if they have friends, and all the stuff I just described. Alrighty, here regarding childhood anxiety and depression. Yeah, the previous mood disorders and anxiety disorders, those categories that we covered in other chapters, can be diagnosed with children. Okay, so like adults, children may suffer from phobias, GAD, OCD, PTSD, yeah, and so on. Okay, major depression, and any of the disorders in the anxiety and mood disorder um, categories. All righty. But just to keep in mind, yeah, important thing to note, very often children, um, adults, teachers, and even healthcare professionals may overlook these particular disorders with children for the reasons mentioned earlier. Yeah, that these kinds of problems don't lead to annoying, disruptive um, behaviors that distress others. That catches people's attention very quickly, and people notice it as long as it's sustained. Yeah, but a lot of these anxiety and depression, and a lot of those mental disorders often are characterized behaviors where people withdraw, don't say things, are quiet, aren't disruptive. Yeah, although they may be in a lot of pain emotionally. Alrighty. But because of the characteristics of anxiety and mood disorders, they may be easily overlooked in children. Yeah. Right. So same disorders aren't as easily overlooked in adults because of their ability to communicate and their inclination to communicate this kind of pain, anxiety and depression to others. Yeah. Children just aren't as inclined or socialized or given the opportunity, perhaps, to express these kinds of feelings as adults do. Okay. Now, with childhood depression, they're less likely to suffer from severe depressions. Yeah. So it may be more of an adjustment disorder with mood problems. It may or may not be a major depression. Yeah. And also, as we had discussed in suicide, children are far less likely to experience suicide. Okay. But already but that's not to say children can't. Okay. Certainly not. It's very rare in early childhood. It's possible, but rare. Middle childhood, it starts increasing more. Certain in adolescence, we see a big increase, but it's still not as high as in young adults and middle-aged people. Yeah. It's just noticeable. We really start taking notice in adolescence because in part because they're also more capable of communicating these feelings. Yeah, but as a general matter, children are less likely to suffer from severe depressive symptoms. But that is not to say they can't suffer from moderate depressive symptoms, which are painful enough. Okay, with that, that's all. I think that's all I have to say. Yeah, that's all I have to say about disorders that typically occur in childhood and adolescence. And with that, I'll see you in our next couple of chapters in Abnormal Psych. Take care. Bye bye.